in the management of uveitis. Please, can you see my slide?
Yes, we can.
Yes, we can.
I'm going to go through this within this short time, looking at giving a brief introduction, talking about the diagnostic challenges, and actually trying to tackle making that diagnosis in uveitis. My talk is going to border mainly on diagnosis. Sorry, my slide didn't seem to move. So we are all aware of the definition of uveitis, inflammation of the uveal tract. That's the list of our challenges. And we know that uveitis affects all age group, affects children, young adults, and elderly. But at least from about 3 studies in Nigeria within the last 15 or so years, we see that the peak age of uveitis occurs within the ages of 35 and 45 years in our country. Uveitis has sight-threatening complications. Sometimes this is worsened by uveitis being present in the 2 eyes. But more importantly, the real sight-threatening complications range from cataract, glaucoma, severe posterior synechiae to cystoid macular edema, and sometimes as bad as getting to retinal detachment. Uveitis can run a very turbulent course. Turbulent sometimes not only just for the patient, even for the caring physician, because of the chronic nature and the amount of disability, the trouble with the medications that are required, and sometimes they're associated with systemic diseases. So therefore, as you're managing the eye, the patient also has to be managed by other physicians, and it will involve a lot of discussion between across disciplines. And I guess worst of all is that it has variable etiology. It can be caused by a number of things: infections, non-infections, and drugs, trauma. And we have also noted that there are geographical differences in the proportion of likely cause of etiology of uveitis. Because of this, there are a lot of tests that may be required that could be useful in determining the diagnosis of uveitis. In fact, battery of tests, catalog of tests, whichever one we call it. But it's also known that when you're seeing an uveitis patient for the first time, if you have done a thorough clinical examination and history taking, you may not need more than 2 or 3 of those long lists of investigation. To make a diagnosis actually refers to the act or acts, depending on which one you want to call it, or in fact, even science, of identify a disease from its signs and symptoms, a constellation of signs and symptoms peculiar to a particular disease through pattern recognition with or without the need for investigations. There are many disorders that may not need investigation. So the diagnosis, that's why once you did not need investigation, you can have a working diagnosis that may be confirmed with investigations. What challenges can come up, or have we noticed in making proper diagnosis of uveitis? These challenges could be patient-related, could be physician or physician practice related, or it could be related to the disease by itself. Patient related, we will not be talking of challenges in managing uveitis without referring specifically to having at the back of our mind our local challenges, our local peculiarities, in addition to all that could be in other places. Sometimes patients present late, and by the time they are presenting with a lot of complications. So the complications begin to mask the presentation that would have the signs and symptoms that would have aided easy diagnosis. Sometimes the patients have used all manner of things, traditional eye medication, other things that would mask the original presentation. Then we have very scanty premorbid ocular health record of the patient. So you're really not starting from the start, and the patient themselves may not know. Sometimes you start your treatments, and in 1 week, 2 weeks, the patient isn't coming back again. And we know that sometimes in uveitis, you're really making your confirmed diagnosis when you're seeing the patient again with the results and maybe with the result of the trial of what you have put in. Physician, not so much can be done about patient-related challenges other than push on with public health information. However, I think the bone of our discussion should be on physician and practice-related challenges and how we can overcome them. One of it is availability of examination equipment. Whatever it is, it's almost impossible to adequately make a diagnosis or manage uveitis without a good slit lamp and equipment to examine the posterior segments very well. Or if you are running a very busy clinic and you're not giving adequate time to take history and to examine the patient, including a full physical examination, then that will be a challenge because that is very important in making the diagnosis. It is believed that up to 90% of the information you need to make a proper diagnosis you will get from taking proper history, past medical history, social and travel history inclusive, as well as examination of the patient. Then if you practice in an isolated place where you do not have access to relevant specialties in this instance, I'm particularly talking about specialties outside of ophthalmology, rheumatologists, pulmonologists, a thoracic surgeon, or some of those pediatricians that would be able to take care of the patient wholly with you. Then we see that sometimes most of the evidence we are using, we are basing our management and even our diagnosis on, are largely imported. So we still have, if we still keep having paucity of locally generated research about uveitis, that could be some problem. But I think that in this instance, we are coming up because I was able to see quite a lot to get about information on uveitis in Nigeria, apart from epidemiology, isolated case reports or sympathetic ophthalmitis, discussions on tuberculous uveitis originating from the country. So it will help the physician to practice properly if we have more research within. And then laboratory support. This is particularly important because if we are taking local samples, they are usually very small. And by the time you send a sample to the lab and the pathologist is saying there is nothing he can see because it is small, maybe that he's not used to it. Or some of us practice in just an eye hospital that does not have some of this additional investigation laboratory along with it for us. Then the disease itself, I tell you, uveitis is not a very friendly disease for anyone because even for the same entity could have variable manifestations. Think of tuberculous uveitis. It could present just as an anterior uveitis, or it can be a pan uveitis in another patient. So, and you know, it's a wide field that we are talking of an anatomical section in the eye, right from the iris back to the choroid, and talking about its neighbors, including the retina. So it can have systemic involvement. If someone has sarcoidosis, while you're bothered about the eye, you may as well begin to think about the chest complications when the patient may start having respiratory difficulties and you're needing someone to do a thoracoscopy, to do a biopsy for you. Then the tests that are available, because of the foregoing, there are a lot of them. The treatment options. Uveitis treatment is not that straightforward. It could also be fraught with a lot of complications. You wouldn't want to keep a patient on corticosteroid for so long. At the same time, you would not put a patient on the biologics or immunomodulatory agents unadvisedly, so you will need assistance. Sometimes it's actually a retrospective diagnosis because you have tried all, you're not getting as, especially you now say, okay, let's do a trial treatment with anti-cox, and then you're getting the result, the required result, then oh, you look back and say, okay, even though you couldn't culture, if you use other criteria, I can actually make my diagnosis presumed intraocular tuberculosis. And of course, disease related because it runs a very turbulent course. I am sorry, I think I have moved my slide too fast. Ouch, I'm having a problem with moving my slide. Yes. So, why do we need to make the diagnosis? To have a targeted and effective treatment. We do not want to beat about the bush. And if we have a diagnosis, we will be able to have adequate prognosis and make a management plan with the patient so that the patient will be involved and know that, oh, I'm dealing with something acute in another 2, 3 to 6 weeks, this will all be gone. Or the patient knows that this is a very chronic disorder and it might actually be present with you for your lifetime. But this and this is how we can manage it. The best time to make the right diagnosis for uveitis is at the first contact, when you're meeting the patient for the first time. So it shouldn't be the time to rush. It should be the time to take all the history possible, including there are history that patients will not volunteer. A patient may not volunteer for you that he has a genital ulcer, except you ask him. Or he may not even volunteer that he has commenced antiretroviral therapy, except you go direct to ask that, to be able to check the signs and symptoms. Seeing all this, the International Uveitis Study Group plus the Standardized Uveitis Nomenclature Study Group have helped a lot by making a standard of classification of uveitis based on the signs and symptoms and the constellation that will be able to assist us to make diagnosis. So this assists us to classify uveitis broadly into anatomical and clinical. The current and the reformed International Uveitis Study Group classification actually speaks about the clinical classification, which goes into classifying uveitis based on the etiology and the other descriptors by the SUN working group, some of which are standardized, some are not standardized. So you could make a full diagnosis, therefore, by clinical assessments of the patient for, like you can have right acute anterior hepatic uveitis, as opposed to just making a diagnosis of, oh, he has uveitis or has anterior uveitis. When you complete your diagnosis as such, then you can have a more tailored workup if you need to, or in fact, you can then do a proper treatment for the patient. So the etiologic classification of uveitis will depend mainly on taking a detailed history and meticulous examination. The most important is to be able to determine, am I dealing with an infectious uveitis or non-infectious uveitis? This is so important. Just imagine not knowing that it is Toxoplasma uveitis one is dealing with, and then you go ahead and give the patient Subtenon Depomedrol. That's sentencing that eye to utter destruction because there is no cover for the infection that is there. Infectious uveitis could be caused by bacteria, viral, fungal, and parasitic origin. And it is believed that infectious uveitis is the commoner type of uveitis in the developing country. Yes, that's part of the imported evidence base. We will need to get more evidence from us. And that is so much important. It looks like there's a lot more of research on non-infectious because that seems to be commoner in the West. Although now with increased travel, everything seems to be flowing into each other because it looks like developing or no developing, things are being imported everywhere. The infectious uveitis, typically the autoimmune related uveitis, they may be associated with they may have systemic disorders or have no systemic disorders. Then the masquerade syndromes, this typically could be neoplastic or non-neoplastic, but usually the concentrated effort is on neoplastic. And of course, others, this is the popular idiopathic. Yes, there could be idiopathic uveitis, but that decision or diagnosis is not made lightly. It is determined after you have sought seriously for other causes of uveitis and they are not seen. Anatomic classification seems to be the easiest of all to classify. It is dependent mainly on the clinical examination, and it is based on the primary site of inflammation. Anterior uveitis, if it is affecting the iris and the ciliary body. Intermediate, if it is primarily within the vitreous. Posterior, if it's affecting the choroid really, but because of close association, really choroid and retina. and then panuveitis if it cuts across. It is worthy of note that this is talking about primary site of involvement. It is possible to have an anterior uveitis, like in chronic anterior uveitis, that can be complicated by cystoid macular edema. The fact that we are saying cystoid macular edema does not mean that there's a posterior uveitis. It's still an anterior uveitis with that complication. Clinical cause and descriptors. This is so important, and it is based on history taking from past medical history to know, have you had this before? What was it like? What were you treated with? And even past and then slit lamp examination. The categories are as such. This is by SUN. The onset, how did it start? Was it sudden or was it of insidious onset? Being just sudden alone is not enough to make the diagnosis of an acute uveitis. If the duration is limited to 3 months or lower than 3 months, then it's a limited uveitis. If it is greater than 3 months, that is persistent uveitis. And both onset and duration assist us to determine the course of the uveitis. We say it is an acute uveitis if the episode is sudden in onset and it is limited. So it started suddenly, and within 3 months, it's all over. So that's where you can have the typical acute anterior uveitis. Many of the idiopathic uveitis fall into this group. Or it could be chronic when you have a persistent uveitis. That is, it lasts more than 3 months. However, it also relapses within 3 months, less than 3 months after you discontinue your treatment. However, this is different from the recurrent uveitis, in which you have repeated episodes separated by periods of inactivity without treatment greater than 3 months. So the patient could have uveitis in January and you have treated it, then by July again, is coming down with another episode altogether. Histologic classification. This is one of the non-standardized classification, but it is based on the form of appearance of the keractic precipitates on slit lamp examination. If you have, we can classify either into granulomatous uveitis or non-granulomatous uveitis. Granulomatous uveitis had large keractic precipitates with dense posterior synechiae. These are the kind of synechiae that just putting in midriasil will not break the synechiae. Presence of iris nodules typically is of insidious onset and runs a chronic course, and it can be associated with invasion of live organisms like tuberculosis or hypersensitivity to some proteins within the body, like you have in autoimmune disorders also. Non-granulomatous uveitis, on the other hand, the keractic precipitates are fine, and then the posterior synechiae is uniform, easy to break. There are no nodules. Usually the onset is sudden and it's of acute course. There are terminologies about uveitis. All these are important because they help you to make the proper diagnosis clinically. And it is dependent on your proper slit lamp examination and documentation such that it's objective. You can come back the next time and say, no, this is worsening. This is inactive. Remember that we cannot make diagnosis of recurrence except we have been examining the patient, because it's not in all cases that you can depend on what the patient says. If it is chronic anterior uveitis that is associated with GRA, it's not, the patient can't tell you my eye is paining me because the eye is white. So you need to depend on your grading scheme for the anterior chamber cells and also for the anterior chamber flare. By and large, many things the patient can present with in form of symptoms will depend on the involvement, the rapidity of onset. So the patient can present with redness, eye pain, photophobia, epiphora. These signs, these complaints are usually more in patients with anterior uveitis component of the disorder. By the time patient starts presenting with floaters, then you know that it is no longer anterior uveitis. This may either be intermediate uveitis or actually posterior uveitis. Decreased vision can be present in any. The signs, some of the signs are peculiar to particular anatomic location, while some cuts across. Keratic precipitate, for instance, you will see in anterior uveitis or the anterior uveitis component of a pan uveitis, while you would be noticing cyclitic membrane, snow banking, snowball opacities in intermediate uveitis. I will leave Dr. Shuaib, who is going to be talking about uveitis, to a retina specialist to detail more on things that pertain to posterior uveitis or posterior components of pan uveitis. But we can see, for instance, that complications like cystoid macular edema can be present in anterior uveitis, intermediate uveitis, posterior uveitis, even as single entities, let alone talking about when it presents as pan uveitis. We will go back to infectious uveitis. Infectious uveitis can be caused by any of these, but I would want us to pay attention to the hepatic uveitis because it causes a lot of recurrent uveitis, and of course the HIV uveitis. Bacterial tuberculosis and syphilis are becoming more important, and many of us are aware of toxoplasma uveitis. What are the peculiarities of hepatic or viral uveitis? Typically an anterior uveitis and presents acutely, can be notoriously recurrent. Most times it is unilateral, except for varicella zoster virus uveitis that can be bilateral, and they are usually associated with raised intraocular pressure. Frequently, this raised intraocular pressure is usually as a result of trabeculitis. And because of this raised, sometimes when they are having a recurrence, it may actually be this raised intraocular pressure that will be present first before it. Now, these days, fixed uveitis is being linked with varicella zoster uveitis, as well as glaucomatous crisis being linked with cytomegalovirus virus. Toxoplasma uveitis. This will usually present either as a posterior uveitis or a pan uveitis. And when it is pan uveitis, it will be granulomatous uveitis, elevated intraocular pressure, and the complications may be seen. Typically, you can make this diagnosis clinically. Tuberculous uveitis is not as friendly. Sometimes you can make the diagnosis clinically easier when the patient also has systemic tuberculosis, but sometimes the patient doesn't have systemic tuberculosis. So you will have to have high index of suspicion, and reading through the review by Dr. Oluleye Aitor will also guide us in this, with knowing that it can be a difficult diagnosis, but remember that it is a granulomatous uveitis. And as we can see, with broad-based posterior synechial, serpinginal-like choroiditis, and large capes, it can present as anterior uveitis, intermediate and posterior or pan uveitis, with so many other things associated with it. Non-infectious uveitis. The anterior uveitis part of it can be caused by many things. The commonest is the idiopathic. Even as common as it is, you can only make that diagnosis after ruling out other causes, including tuberculointerstitial nephritis, associated uveitis, lens-induced uveitis, and drug-induced uveitis, as the patient be on antiviral, antiretroviral therapy. And one of the presentations of anterior uveitis sometimes is in its chronic form, chronic anterior uveitis, commonly associated with juvenile idiopathic arthritis, fixed heterochromic arthritis, in all of which the eye is usually white and usually presents as a unilateral disease. If it has stayed long enough, cystoid macular edema is a common complication. Intermediate uveitis is usually bilateral, but it could be asymmetrical. In fact, it's usually a self-limiting disorder. It may be asymptomatic. You may never see it until it pops up in one eye after you have done a cataract surgery, or you have a reason to just dilate, or sometimes for patients that keeps complaining of floaters. And majority of them are not associated with systemic disorders. But if you look at the list of the possible systemic disorders they can be associated with, in just that's about 20%, you'll see that they can be associated with infectious and non-infectious causes of uveitis. Posterior uveitis, I'll leave that to Dr. Shuaib. Now I will just run through some of the things that can cross your mind and aid you in making this diagnosis when you're seeing the patients in the clinic. Patients that will usually have non-infectious panophthalmitis, panuveitis. I have described infectious panuveitis, TB, syphilis, and co. You can have that non-infectious panuveitis. You think of sarcoidosis, sympathetic ophthalmia, Voss-Koyanagi-Harada syndrome can also present like that. And then for panuveitis from sarcoidosis, you're going to be looking at paying attention to the non-ocular disorders that could be associated with it. Typically, it is a bilateral disease with granulomatous anterior uveitis. It will involve all other parts of uveitis, and it will also sympathetic ophthalmia. You could get that just knowing that the patient had had a surgery or a previous trauma. Behçet's disease will also be granulomatous anterior uveitis. It may come with hypopion and the ulcers with it. Post-operative inflammation will be, as we have already discussed, maybe IOL related or not, and then the masquerade syndrome. In real life, the main thing, as I'm rounding up now, is disease pattern recognition. If it is unilateral and always in the same eye, viral. If it is both eye, but it comes at different time, right this time, left the other time, is likely to be that associated with HLA-B27. Bilateral anterior uveitis, please, at the same time, think of those associated with systemic disorder. I have talked about granulomatous and those that can be associated with pigmentary changes, viral. If he's having hypopion, think Behçet's disease. If he's having raised intraocular pressure right at presentation, think of sarcoidosis, Pochner-Stosler syndrome, and hepatic uveitis. And of course, we have described the keratotic precipitate. Diagnostic workup must be tailored based on what you have made your diagnosis as clinically, the working diagnosis. Is just to confirm and maybe to assist in treatment. Extensive investigations are only used in very rare conditions and for research purposes. A barrage of tests can be done. ESR, mainly important for non-infectious uveitis. Full blood count can be non-specific, and then for specific cases like in lymphoma, quantiferon gold, for TB, chest x-rays, and CT to confirm sarcoidosis and TB, ELISA test, and of course, polymerase chain reaction. This is very important where it is available because you have to take samples, aqueous samples, very little samples that will be useful. So what are the key points to note in these diagnostic challenges? The correct diagnosis is important for effective treatment. Please don't forget, you must differentiate infectious from non-infectious. Once you see one, that's the first thing to think of. Is this infectious or non-infectious? Note also that most of these patients do not require more than 2 or 3 investigations to start with. Remember to think of social, travel, past medical history, physical examination, detailed record, because you will need it to compare and to think back just in case you have missed your diagnosis. You will need to involve all that discipline as we take care of uveitic patients. Thank you very much. I use these references.